Hello and welcome to the Alliance for Home Health Quality and Innovations webinar on the Home Health Chartbook, Updated Data and Trends for Home Health Care in the United States. My name is Teresa Lee, and I'm the Executive Director of the Alliance for Home Health Quality and Innovation. By way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients in the entire U.S. healthcare system. The webinar today will focus on the compendium of data that the Alliance commissions on home health care in the United States. The Home Health Chartbook was commissioned by us from Avalere Health, a healthcare consultancy that works with healthcare stakeholders to improve care delivery through better data insights and strategies. We're very fortunate today to have as our guest speakers Ellen Lukens and Lily Hummel of Avalere Health. Ellen Lukens is a vice president at Avalere, and she provides strategic support to a broad array of clients interested in better navigating the current and future hospital and post-acute care delivery and payment environment. She has expertise in assisting clients who are working to transform the way healthcare is delivered and leads strategic planning engagements with clients. Prior to joining Avalere, Ellen worked at the National Association of Public Hospitals and the Greater New York Hospital Association. Earlier in her career, she was a policy analyst in the Centers for Medicare and Medicaid Services, or CMS. Ellen has a BA from Northwestern and an MPH from the University of Michigan. Lily Hummel is a manager at Avalere, where she advises clients on regulatory and legislative developments in the post-acute and long-term healthcare sectors. She applies her background in policy analysis to help clients define policy alternatives and understand impacts, navigate payment and healthcare delivery systems, and understand key regulatory and legislative changes. Prior to joining Avalere, Lily was an analyst with the Government Accountability Office and a program assistant with both the Wisconsin Legislative Council and the Population Health Institute. Lily has a JD from the University of Wisconsin Law School, a Master's of Public Affairs from University of Wisconsin-Madison, and a BA from Carleton College. Just a few housekeeping notes before we get started. First, Ellen and Lily will speak for about 40 minutes, and we'll leave the last 15 minutes to answer questions. Please note that this is a webinar, and we control the slides on our end, so please don't be surprised if you cannot flip ahead. Second, your lines will be on mute. You can submit questions to be answered during our Q&A period through the Fuse webinar software on your computers or other devices. And finally, we will be posting the slides on the website after this webinar, and we're also recording the webinar, and we'll post the playback on the Alliance's website. And with that, I'd like to turn this over to Ellen.
Thank you very much, Teresa, and thank you to everyone for joining the call today. The purpose of the call today is to review some research, as Teresa said, that Avalere Health conducted on behalf of the Association for Home Health Quality and Innovation. The goal of this research was to better understand how those Americans using home health care services do so. And the results of this research show what many home health care operators have been saying. Home health users are more likely to be older, racial ethnic minorities, more likely to be women, have more chronic illness, and have lower incomes. And we'll be showing you slides during the course of this webinar that demonstrate these findings. This is an important topic, particularly given the evolving provider and payer relationships. The research provides some context when considering delivery system innovations and policy proposals, as it focuses principally on the patient, but also on the home health providers. As Teresa said, my name is Ellen Lukens, and I lead the provider practice at Avalere, and Lily Hummel and I will be conducting the webinar today. As Teresa said, we're going to share the research with you and then open up the line for questions. As you will see, and as Teresa said, we will be moving the slides, but you will have access to the full chart book at the conclusion of the webinar. We will not walk through every slide, but instead will highlight key findings. If you have any questions following the presentation, please don't hesitate to reach out to Lily, me, or Teresa. Our contact information is included on the last slide. With that, we will jump into the data. So we'll start with section 1. which provides an overview of the demographics of the home health population.
So while Ellen's working the slides, I'll walk you through what you can expect to learn about in this section. This section profiles the home health population, that is, Medicare home health users, as compared to all Medicare beneficiaries. It includes information on demographic characteristics, including age, race and ethnicity, gender, income, dual eligibility status, and those home health users with severe mental illness, SMI.
Perfect. So this is slide number 4 of the chart book, but you'll see on the top it's chart 1.1. And what this shows is the age distribution of home health users versus all Medicare beneficiaries. As you see, home health users are disproportionately older. 37.1% of home health users are between ages 75 to 84 versus 27.2% for all of Medicare. Just over a quarter, or 25.3% of home health users are over age 85 versus 12% for all Medicare beneficiaries. So what we're showing here is that the oldest of the old, the 85 plus, 25% of home health users are over 85 plus. We'll now turn to chart 1.2. What we show here is that home health users are more likely to be female when compared to the overall Medicare population. As you see here, 62.9% of Medicare home health users are female, while 55.1% of all Medicare beneficiaries are female. Chart 1.3 shows that Medicare home health users are also less likely to be married and are more likely to be widowed or to be separated, divorced, or never married. So you see that here, where if you look at the home health users, only 38% are married, whereas if you look at all Medicare beneficiaries, 51.9% or almost 52% are married. And chart 1.6, I want to draw your attention to this chart, which provides a summary of several demographic characteristics of home health users versus all Medicare beneficiaries. As you see, home health users are more likely to be older, live alone, have 3 or more chronic conditions, 2 or more activities of daily living limitations, report fair or poor health, and have lower incomes. Now, I know this is a lot of data in one slide, but I think it's a nice summary chart which helps demonstrate some of these metrics that we talked about before, but also some additional ones. For example, if we look at the proportion of beneficiaries that live alone, we see that home health users are substantially more likely than other Medicare beneficiaries to live alone. Similarly, they're much more likely to have 3 or more chronic conditions. We have 85.9% of all home health users with 3 or more chronic conditions, whereas only about 62.9% of all Medicare beneficiaries. You see here we also talk a little bit about ADL limitations, and what those reflect are functional limitations. So we show here that 34% of Medicare home health users have 2 or more ADL limitations, whereas of all Medicare beneficiaries, only 12.8% have 2 or more ADL limitations. The final thing I wanted to note on this slide is we also show income and related to home health utilization. You will see here on the bottom where we measure the proportion of home health users versus all Medicare beneficiaries that have incomes under 100% of the federal poverty level. And what you see here is that home health users are more likely, 32.6% of them, have incomes that are below 100% of the federal poverty level. For reference, 100% of the federal poverty level for a single person in 2012 was 11,170. I'll now turn to chart 1.7. This chart uses data from the Bureau of Labor Statistics to show annual living expenses for households with incomes under 200% of the federal poverty level with at least one individual 65 years or older. You can see that for a one-person elderly household, out-of-pocket healthcare costs comprise nearly 16% of their entire budget. This is important data to keep in mind should policymakers discuss increased cost sharing for Medicare beneficiaries, including potentially co-payments for home health care episodes. Please note on this slide that these metrics apply to all Medicare beneficiaries, not just home health users. If we turn to chart 110, you'll see here that we provide some data and insight on home health users by race. Chart 1.10 on slide 13 shows that although Black and Hispanic home health users are about as likely to have 3 or more chronic conditions as all Medicare home health users, Black and Hispanic home health users are more likely to report fair or poor health status. And in chart 1.11, we show that Black and Hispanic home health users also tend to have income under both 100 and 200% of the federal poverty level when compared to all Medicare home health users. And you see that here we show income under 200% of the federal poverty level and income under 100% of the poverty level for home health users, and we show those by race and ethnicity. If we move ahead to slide 19, which is chart 1.16, we show the dual eligible status of home health users versus non-dual eligible home health users. The chart shows that dual eligible home health users, that is, beneficiaries who are eligible for both Medicare and Medicaid, are more likely to have 5 or more chronic conditions. A variety of conditions are considered chronic conditions, including high blood pressure, arthritis, diabetes, heart failure, and Alzheimer's, and those are some of the most frequently reported. So if you look here on this pie chart, you see that of the dual eligibles, and these are folks who are home health users. So in these pie charts, you are actually only seeing home health users. And what we've done is we've separated the home health users into those that are dual eligibles and those that are not dual eligibles. And what this graphic shows is those that are dual eligibles are more likely to have 5 or more chronic conditions. Almost 58% have 5 or more chronic conditions, and you see that in the dark blue. In terms of the non-dual eligibles, only 48% have 5 or more chronic conditions. Still a substantial amount, but it does show that the disease burden is higher on the dual eligibles. The final portion of this section, and we'll turn to chart 119 now. The final portion of this section gives an overview of the proportion of home health users that have severe mental illness versus the overall Medicare home health population. And as you see on slide 22, Medicare home health users with severe mental illness are more likely to have 3 or more chronic conditions, 2 or more activity of daily living limitations, report fair or poor health, or report being in somewhat or much worse health than the last year. So here we're showing home health users and their status, whether they have severe mental illness or whether they do not have severe mental illness. And you see, what you really see here is a similar pattern that you see for utilization of a lot of Medicare services, with those folks with severe mental illness using more services and also greater Medicare program expenditures directed to those beneficiaries. So this pattern is not unusual among other services as well. Finally, on chart 121, which is slide 24, you will see that home health that 27% of the home health population has a severe mental illness versus 18% for the overall Medicare population. And what this shows is that of home health users, 27% have a severe mental illness. So we've already documented that these beneficiaries have a greater disease burden. They tend to be older, they tend to be female, less likely to be married, and also more likely to have severe mental illness than the overall Medicare population. With that, we'll turn to Section 2, which is the clinical profile of home health users. So this section, as it's labeled, really focuses on the clinical characteristics of the home health users, and we'll just highlight a few of the charts in this section to give you a sense of what is included. So in Chart 2.1, you will see the most common hospital MSDRGs for beneficiaries who are subsequently treated for post-hospital care by home health agencies. And by this we mean that these are folks for whom, after they are discharged from the hospital, they receive care from a home health agency. So Avalere reviewed a 100% sample of all fee-for-service beneficiaries who had a hospital admission in 2012. And we then linked those hospital claims with the home health claims to see who received home health services following the hospital admission. For those beneficiaries that did receive home health services, we then explored what hospital MSDRGs were. As you will see in this chart, the most common MSDRG is major joint replacement or reattachment of lower extremity without major complication or comorbidity. And this represents over 10% of all hospital cases referred to home health. There are a total of 753 MSDRGs. As you see here, about 37.7% of home health cases are concentrated in the top 20. So if you look here, what this really shows you is some of the most common hospital conditions that then are subsequently treated or for rehabilitation or therapeutic care following the hospital discharge. And so what we see here is that major joint replacement is the most common. There were almost 200,000 home health Part A claims related to that. After that, though, it drops down fairly quickly. And you see the second most common is septicemia or severe sepsis. That is followed by heart failure and shock, and those are the two, one with complications and comorbidities and the other with major comorbidities. I think if you were to characterize these clinical conditions, they would fall in broad categories, but certainly some of the large categories are cardiac, orthopedic, and then septicemia, and you'll see those repeating. I think also you see COPD, and some of those, as you know, represent the larger conditions for which, the larger MSDRG volumes. If we turn now to Chart 2.2, we now show the condition for which the beneficiary, this one is actually this slide 2.2 shows the chronic conditions among home health users. So what this shows is the diagnoses or the ICD-9 codes that were included on home health claims. And so what we did here is we mined the home health claims data, and we looked at, for the home health claims, which ICD-9s appeared on them. So if they appeared only once, they were still included. What we show here is that over 9% of home health Part A users, so these are the folks that are receiving home health care after the hospitalization, had diagnoses of diabetes. You also see other common diagnoses like some of the orthopedic, but also some of the chronic conditions like heart failure, hypertension, and some of the other, like the COPDs. If we turn now to Chart 2.3, what we show here is the percent of Medicare home health users by state with 3 or more chronic conditions. And so we broke this down on a state basis. We show home health users and the percent of Medicare beneficiaries overall. This is interesting because you see the degree of variability among states, but also really the difference between home health users versus all Medicare beneficiaries. And what you see consistently across all states is that for home health users, the chronic condition and disease burden is much greater than it is for all Medicare beneficiaries. If you look here, there are some interesting phenomena around the states where you see there are some obviously pretty large shifts. If you look at states like Hawaii, they have only 11% of Medicare beneficiaries with 3 or more chronic conditions, where you have other states like Vermont, where that's more than 40 for the overall Medicare beneficiaries. For the home health users, there's also some variability, not quite that dramatic, but in most states, the beneficiaries that are using home health generally have 3 or more chronic conditions. The next section we'll turn to is Section 3, the post-acute care market overview. And just to reiterate, this entire chart book will be available for your download after this discussion, and we are happy to answer any questions related to these slides after. We will not walk through every one on this webinar. So Section 3 provides an overview of the post-acute care market, and it's really to provide some context about the home health providers and agencies. So if we turn to chart 3.2, this chart shows for all Medicare patients that have a hospital stay where they go upon discharge. So if you look at the big pie chart on the left, we are saying of all the patients that were hospitalized, the Medicare fee-for-service beneficiaries that were hospitalized in 2012, where did they go afterwards? And I think one thing that's really interesting is that you see on the left, that blue section of the pie, that 57% went home to the community with no home health. You then have 3% that died, and you have 3% that received some care in a non-post-acute care setting. Just to give you a sense of what that might be, one example would be a psych hospital, so another inpatient hospital. But 37%, and that's in the gray, did receive some form of formal post-acute care. And of those, 1.4 million, or 37% of that gray portion of the pie, received home health care. And I think this 1.4 million patients really demonstrates home health's important role as a post-hospital partner. Because what this shows is that after a hospitalization, there were 1.4 million home health episodes. So again, that just shows how many folks are using home health care after a hospitalization to help them with rehabilitation and therapeutic care. Charts 3.3 through 3.6 show the initial patient destinations by regions, and these regions are defined by the U.S. Census Bureau. So you'll see here in chart 3.3, we show the northeastern region. And these can be a little bit hard to read, but I think these are really, really interesting because they show you the extent of the variability among states in how they're using services. So I'll just take a moment to walk you through this, and then subsequently, when you look at the chart book afterwards, you can look at your region or other regions that you may be interested in. So what this is showing you is for 100% of the Medicare fee-for-service beneficiaries, what we did by state is we looked at after a hospitalization, where did the patients go? And what we looked at here is after hospital discharge, what percentage of patients went to each destination. So right now what I'd like to do is contrast Connecticut with New Jersey. So if we look at Connecticut, only about 42% of their beneficiaries went back to the community after a hospitalization. And what we see here is that they have substantial skilled nursing facility utilization, as well as substantial home health utilization. They have very little LTAC utilization. You see that in Massachusetts, and that's that top bar, that's dark blue. You see in Massachusetts, it's about 2%. If we were to shift over to Texas, you would see that being a little bit higher. What we've done here in terms of the numbers is shown the percentage of home health. So you can see how that varies. You have a full 20% of beneficiaries in New Hampshire using home health, whereas you only have 15% in New York and Maine. Now, one thing about contrasting New Jersey with Connecticut is you see that New Jersey, over 50% of beneficiaries go home with no subsequent post-acute care, and in New York that number is even higher. So you see, even within the northeastern region, there's a fair amount of variability in how people receive post-acute care. And I think some of that variability is what's driving some of the post-acute care delivery and payment system innovations and efforts around reform. Just one last note about this. If you're looking at the more neon green bar, which is more toward the top, just above the percentages, you see there that that's inpatient rehabilitation facilities. And the percentage of folks going to those facilities, even though small numbers, vary substantially across states. So with that, the remainder of these slides in this section, in the 3.3, show the different regions, the different census regions around the country, and break down by state the post-hospital utilization. So we will now be turning to section 4, and I will turn over the webinar to my colleague, Lily Hummel.
Hello, thank you, Ellen. So we're now going to start talking about section 4, which is Home Health Care Services, the industry workforce. So this section shifts the focus from the beneficiary to the home health care workers and the home health agencies. We'll start with chart 4.1. This chart shows the number of home health care aides according to the Bureau of Labor Statistics. After the number of aides decreased from 2011 to 2012, we start to see that number rise again in 2013 to just over 332,000 home health aides in 2013. In the next chart, chart 4.2, we'll see that the Bureau of Labor Statistics is anticipating a large increase in the demand for aides. As you see on this slide, they're anticipating an over 90% increase in the number of aides from 2010 to 2020. This is driven largely by demographic projections, that is, the aging of the baby boomers, and the anticipated increase in demand for home health. And lastly, in this section, we'll look at chart 4.3. 4.3 shows that the overwhelming majority of home health care workers are women. Over 87% of home health care workers are women, according to the Bureau of Labor Statistics. Next, we're going to move on to section 5, organizational trends in home health. So if we can move forward to chart 5.1, you'll see this section is going to provide data regarding the organizational trends that are occurring in the home health industry. As chart 5.1 shows, the number of home health agencies has been growing steadily for over a decade. As of the end of 2012, there are 10,544 home health agencies according to Medicare cost report data, and about 7.5% of those freestanding agencies also offer private duty nursing. On chart 5.2, we see the breakdown of agencies based on their number of employees as collected by the Census Bureau. 30% of these firms are very small, with 4 or fewer employees, and over half the agencies have 99 or fewer employees. So if we look here, you can see in the neon green that only 1% of agencies report having over 500 employees. So for the most part, home health agencies tend to be very small with a smaller number of employees. Going on to chart 5.3, this slide shows data from the Medicare Standard Analytic File, or the claims data. In this slide, we see that both Part A and Part B covered home health episodes grew steadily from 2006 to 2011. However, Part A episodes remained the same from 2010 to 11 and actually decreased a little bit in 2012. Meanwhile, the number of claims covered by Part B continued to increase until declining in the most recent year of data shown here. In 2012, 2.46 million home health episodes were covered by Part A, while 4.4 million were covered by Part B, which means that Part B was covering the vast majority of home health episodes. Moving on to the next chart. This next chart, whereas the last one showed the number of home health episodes, this slide shows the number of Medicare beneficiaries who had a home health episode. Similar to the prior slide, this number also grew between 2006 and 2011 as more and more beneficiaries had episodes covered by Part B. According to our data analysis, the number of beneficiaries with an episode covered by Part A actually decreased slightly to 1.7 million in 2012, while the number of Part B covered episodes continued increasing slightly to 1.94 million in 2012. The number of beneficiaries with episodes covered by Part B could be increasing for a number of reasons. An increasing number of beneficiaries may be exhausting their Part A benefits, or there could be an increase in the number of beneficiaries who are using the home health benefit that don't first have a 3-day inpatient hospital stay, which means that the benefit would be covered by Part B. Moving on to chart 5.5. This shows the number of beneficiaries with a home health episode. Oh, can we go back to 5.5, please? Thank you. 5.5 shows the number of Medicare beneficiaries with a home health episode by state. So not surprisingly, given state size and demographics, we see here that Texas, Florida, and California have the most beneficiaries with a home health episode, while Alaska, Hawaii, and Wyoming have the fewest. And then to move on to chart 5.6, thank you. This shows the average number of 60-day episodes per home health user, which has remained fairly constant. So what we're seeing here, if you look at the green bar is showing you for each year the average number of episodes per beneficiary that had a home health episode. So everybody counted for this data display had at least one episode. So what you can see is that the number has remained fairly constant over time, though the number of overall home health claims, the average number of episodes did go down slightly from 2011 to 2012, dropping just under an average of 2 episodes per user. Now we're going to move on to section 6, which covers the economic contribution of home health agencies. This section uses several data sources to estimate the economic contributions of the home health industry. If we can move to chart 6.1, please. This shows the estimated economic contribution related to home health jobs in each state. I'm going to walk you through how we did these calculations so you understand each column of data. This analysis used state employment data for 2012 from the Bureau of Labor Statistics Quarterly Census of Employment and Wages. The BLS, the Bureau of Labor Statistics, collects monthly data and quarterly wage data from reports filed that's mandatory to be filed by nearly all employers in all 50 states, D.C., and Puerto Rico. This data reporting is mandatory for privately owned home health agencies, which includes both for-profits and nonprofits. Several states also include for the BLS their employment figures for the agencies that are owned by local and state government, which we've also included in this analysis. where available. So to calculate the total number of jobs created by home health industry for each state, we multiplied the number of home health jobs reported to BLS, which is the number that you'll see in each table. It's the number on the left, so estimated number of home health employees. We multiplied that by a multiplier from the Bureau of Economic Analysis. The multiplier, which is in the middle column of each table, is intended to yield the total number of jobs created indirectly and directly by the home health industry. So although the BLS jobs data do not include the number of jobs, for example, for home health contractors, the multiplier is intended to account for such jobs. The multiplier attempts to quantify additional jobs created based on the ripple effects of expenditure and demand produced by home health employees. So for this calculation, we can see in the bottom right that the estimated total number of jobs created by the home health industry is just over 1.7 million jobs in 2012. So this is not specifically related to the payer type. This is not a Medicare-specific analysis. This is an overall capture of, as reported to the BLS, the number of jobs created by the home health industry in aggregate. Moving on to chart 6.2, this shows an estimate of the indirect impacts of wages paid to home health employees on total labor income in each state. So similar to the analysis that I explained for chart 6.1, we again multiplied the wages as reported to the BLS by a multiplier to get the overall estimated impact on labor income. So to take a specific example, let's look at California. With California, each dollar paid to the home health worker generates 64 additional cents in terms of total labor income. So looking at California, you can see that their multiplier is 1.64, so that's where the 64 extra cents is coming from. So that as the employee, a home health employee, spends his or her wages on goods and services, that in turn creates this ripple effect, contributing to other labor outcomes. As a result, in California, we can see that the estimated home health wages in 2012 just for home health are a little over 2.3 million, and then once we apply the multiplier, the estimated indirect impact overall from the home health industry is 3.8 million. Moving on to chart 6.3, this is the final slide using a similar methodology, which estimates the impact of home health on output by state in 2012. So this is taking into account additional jobs, wages, and other economic effects generated by the home health industry. If you look again in the bottom right, what we see is a total estimated impact of home health on output of nearly $80 billion in 2012. And the last table we'd like to highlight in this section is chart 6.4. This uses Medicare cost report data to estimate the impact of home health on jobs over time. So we can see that the number of jobs in home health continues to increase. Moving to section 7, we're going to talk briefly about outcomes for home health users. So this next section, if we look at chart 7.1, thank you, provides data related to outcomes, specifically focusing on rehospitalization among post-acute care users. Using the claims data, we show the 30-day rehospitalization rate for patients with a variety of diagnosis codes, the DRGs that Ellen talked about earlier. For comparison purposes, we show the rehospitalization rate for patients who first went from a hospital to a SNF, which is the data that you're seeing on the far right, and then we showed the rehospitalization rate for patients that went directly from the hospital to home with home health care. It is important to note that these data are not risk adjusted beyond the adjustments that are already included in the DRG code groupings. For both home health and SNF, the rehospitalization rates were lower in 2012 than in 2011. So in 2011, the overall home health rehospitalization rate was about 19.1%. That's compared with what you're seeing on the screen here, almost 17.4, so 17.39% rehospitalization rate. So that's a pretty decent decrease, and we see a similar trend in SNF, where the rate dropped from 20.05% in 2011 to what you see on the screen here, 18.23%. And just as a general frame of reference, the national readmission rate has hovered around 19% for several years and is generally decreasing. During 2012, the 30-day all-cause hospital readmission rate was reportedly 18.4% for Medicare beneficiaries. So that just provides you some context. If we move now to chart 7.2, the next two slides in this outcomes section are going to provide some data from the Medicare Home Health Compare website. So this chart in 7.2 shows the national averages for home health agency performance on certain process measures, or measures that assess whether the home health care team performed certain actions. On average, home health agencies scored higher on these measures, and we didn't see any decrease in performance from the earlier time frame, which was April 2012 to March of 2013, to the similar time frame a year forward, so April 2013 to March 2014. Now if we move to table 7.3 next, this shows outcome-related data from Home Health Compare. This gauges whether patients experience certain outcomes during the course of their home health care. On average, a slight majority of patients did show improved functioning. I should note that the percent that had to be admitted to the hospital dropped from 17 to 16%, and for this one metric, a red arrow down is actually a positive change because we'd like to see a reduction in the number of patients admitted to the hospital. So this concludes our walkthrough of the chartbook. Before we conclude, though, I'd like to walk you through some additional data analysis that we conducted with the Alliance. So if we can flip through two more slides, I believe it's slide 63 overall. If you go through and then right to this slide, thank you. This year we created 3 additional decks besides the chartbook. So the first one you see listed here, the prevalence of chronic conditions among home health users, is an update of data that we created last year. So I know on the Alliance's website they still have the link to last year's chronic condition by state deck, so you can look and compare across years. The next 2 are new decks that we put together this year, and I should note that what each of these are doing are providing data by state, and the national level data are in the chartbook. So the second publication listed on this slide is showing the top MSDRGs and ICD-9 codes for home health episode by state. And then the third is using some survey data collected by the BLS to break down the annual living expenses for those under 200% of the federal poverty level. I pulled some samples, just Alabama slides from each of these decks, just so that we could walk through briefly and give you a sense of what data are available in each of the 3 new publications. So if we could go to the next slide, please. Thank you. This is showing the percentage of home health users by the number of chronic conditions as compared to all Medicare beneficiaries, specifically for home health users in Alabama. What this is showing for this state in particular is that 63% of their Medicare home health users have 5 or more chronic conditions. However, nearly 3/4 of the state's entire Medicare population have 0 to 2 chronic conditions, which is an astounding gap between the all Medicare population and the home health user population in this state. If we can move on to the next slide, please. The next two slides are from a new publication this year that offers two different data points. So for each state, we have two different slides. This first slide shows the top 10 most common DRGs for patients discharged from a hospital directly to a home health episode. So as you'll see in this state, for example, in Alabama again, just as major joint replacement was the top DRG at the national level, it's still the top DRG at this state level. And I think that that's probably going to be the case for most, if not all, states, but you will see a little bit of variability as you go through the states in which other conditions are underneath major joint replacement. And if we go to the next slide, please, that's going to show the top conditions for home health episodes. So whereas diabetes was the top condition at the national level, here other orthopedic aftercare was actually the top condition, followed closely by diabetes. So this provides another interesting data point that would allow you to compare across states and compare your state to the national average. And then moving on to the next slide, these final two slides show the average annual living expense for households below 200% of the federal poverty level with at least one individual who's 65 years or older. These data are based on Bureau of Labor Statistics Consumer Expenditure Survey data. I should say that since this is survey data, there were not data available for every state. So the majority of states are represented in this data, but we did not have survey representation to reflect all of the states. So if you scroll then to the next slide, you can see the two slides that will be represented for each state for which there were data. And so then if you go to the last slide, it just shows our contact information. This concludes our presentation of the Home Health Chartbook and the additional publications. If you have any questions or would like to further discuss Avalere's data capabilities or analysis, please feel free to contact Ellen or myself, and this screen gives you our contact information. And now, Teresa, I can turn it over to you if you'd like to moderate questions and answers.
That's great. So thanks so much, Ellen and Lily. That was a terrific overview, and I want to apologize to everybody on the phone for the technical difficulties. As I mentioned at the very top of the hour, you can submit questions to our speakers via the webinar chat function. So please do so at this time if you have any questions. I don't think that we have any questions at the moment, but I'm encouraging you to ask some. So while we're waiting for people to think about what questions they have, I thought I would ask Ellen and Lily what they thought about the variance over time with respect to the change in Part A and B beneficiaries with a home health episode. I think this is I'm looking at charts 5.3 and 5.4, and the fact that we're seeing sort of a decline in the number of Part A and Part B episodes between sort of an increase over time through 2011, and then a decrease in 2012 is seen in chart 5.3, and then in chart 5.4, just to see that actually the number of beneficiaries is about the same. So anyway, I just wondered if you could talk about what you think might be happening in the health system that might be driving these types of changes.
Yeah, Teresa, that's a great question. This is Ellen. I think a lot of what is driving that is, if you think about Part A home health utilization, it by definition has to be following an acute care hospitalization. And what we've seen, and I think there are a lot of different explanations for it, but what we've seen is that there is declining inpatient hospitalizations. And so as a result, since there are fewer folks being hospitalized, there are fewer than getting sort of Part A covered home health services afterwards. And you'd see a similar dynamic if you looked at like skilled nursing facility utilization. It looks very similar to this. So we think the primary driver of both of those is really the reduction on the hospital side and the decline in hospital utilization.
Interesting. And then, we talked a little bit, and you guys talked a little bit about sort of the decrease in 30-day readmission rates for the top 20 most common MSDRGs. That's table 7.1. And I do think it's just really interesting that we're just starting to see reductions in 30-day rehospitalization rates across the board, not just for 30-day readmissions from home health, but also from SNF, and then just a decline in the overall. I mean, clearly some of these changes are being driven by the readmission penalties that the hospitals are receiving. I guess I'm wondering if you're thinking that we're gonna continue to see a decline in readmissions, and then also whether you think that there are other quality measures that we need to be looking at as the rehospitalization rates go down, sort of in combination with this particular measure.
Yeah, so I think the short answer is yes, we expect, and first of all, let me just confirm, again, this is Ellen, that I think that Lily and I completely agree, Teresa, that part of the reason we see the reduction is really, we saw that happen really after the penalty. So you see that hospitals reacting to that, and also really focusing on what are clinical processes and care transition pathways that we can put in place so we can reduce the number of readmissions, which I think everyone agrees is like a poor outcome. So I think we will see more movement there. I mean, one thing that's interesting about the readmission penalty and how it works is that it floats. So as hospitals do better, they all have to continue doing better, because if you're in the bottom, you're still in the bottom. So the bar keeps on getting more and more difficult to reach. So in terms of other metrics, I think we have seen a lot more, like, for example, some ACOs, putting into place a broader set of metrics by which they're evaluating their partners. So I would say in terms of rehospitalizations, I think that there are folks definitely also considering outcomes like observation stays or ED visits, which I think speak to your question of, are there things that are kind of not rehospitalizations but still sort of poor outcomes? And I think those are two that pop into mind. But I think in terms of some of the ACO metrics that we've seen, they can be actually even much broader. So they can include things like patient satisfaction with care. They can also include metrics such as, was somebody who had skilled nursing facility care, were they assessed to see if they needed home health care? So I think those metrics can be also a lot more in-depth depending on the organization.
Great. Yeah, I was thinking too that, there may come a point in time, and I personally think that we should look at these matters sooner rather than later, asking the question, to what extent are we confident that the reductions in rehospitalization rates are truly reflective of higher quality of care as opposed to issues that, could be more troubling for patients because it's a utilization measure as opposed to, it's certainly one type of outcome measure, but it's more reflective of utilization than it is necessarily quality in certain cases. So, I think that over time that's something we need to really try to figure out. How can we be confident that quality of care is truly being improved? And right now, I think that the 30-day readmission rates are so high that you've got there's no other option than to seek to reduce it. But I do think that we can aspire to better in terms of quality measurement. That's my own personal opinion. So here's one question that came in via our chat box. It comes from Vicki Hoke, who's with the Pennsylvania Home Care Association. Her question is, what are your thoughts about the higher number of beneficiaries going to skilled nursing facilities versus home health following a hospitalization? And she's wondering whether or not it could be the case that maybe there are discharge planners who might be unfamiliar with what home health does. I don't know what do you think about sort of the breakdown between the percentage that goes to SNF versus home health?
Well, I think certainly the majority today do go to skilled nursing facilities following hospitalization. I think her question is really an important one, particularly in the broader context of some of the payment and delivery system reforms like bundling or ACOs, where providers are really asking themselves, is this the most cost-effective setting that meets the clinical needs of the patient? And so I think that in some cases we are seeing organizations think about home health as a substitute for nursing facilities in cases where they feel like it's clinically appropriate, that the home health agency can provide the kind of clinical care that the patient needs after the hospitalization. Mm-hmm. I mean, if you think about how these providers have evolved over the past 10 years, all of the services look so different. So it's hard for me, and probably for all of us, to really think about, like, what will home health care look like in 10 years. But I think we would probably all agree that home health care today looks really different than it did 10 years ago, and similar to skilled nursing facilities.
Yeah. I mean, I go ahead, Lily.
Oh, the other thing I would add is I think it's very market specific what the discharge patterns are and who the dominant players are in that market. So I think to answer Vicky's question is challenging just because it varies a lot based on whether or not, for example, there are LTACs and IRFs in the market, or a very dominant large SNF that has a lot of relationships with the hospital. But I do think that there's an opportunity for home health operators to understand their readmission statistics and their other quality metrics and get in there to be talking with the hospitals and health systems in their area, because I do think there's potential for the volume to shift. It's just a question of taking advantage by knowing, so to speak, your value proposition and educating your upstream referral partners about the benefits of home health for patients where it's clinically appropriate.
I think it's a really interesting question too, and I've wondered just sort of, personally, to what extent does some of the percentage difference between those who go to SNF versus home health, how much does it have to do with whether there's a caregiver at home, for example, because that's so important if you really want to be able to receive home health care. And if you don't have any other kind of caregiving support, then maybe that tilts the balance towards skilled nursing facilities, which to me seems like a shame, because we should be able to garner that kind of support, and it would be more cost-effective for the government and probably patient-preferred to be able to go directly home. But there might be, like you said, many different factors, including market factors. We've got one more question here. This comes from Barbara Hanna. And her question is whether you think that hospital observation stays are increasing or changing at the same rate as or in the same sorts of patterns as the slides 5.3 and 5.4. I'm going to pull up 5.4 so that I'm looking at it. Oh, she's talking about the home health episodes. Yeah, I mean, do you think that changes in the number of observation stays might relate in any way to the home health episodes here?
I'm not sure, because the observation stays, if you have an observation stay, and the folks on the phone probably know this better than us, but if you have an observation stay, even though you might be in the hospital, in a room in the hospital, if you're not formally admitted and you don't have the 3-day hospital stay, you don't necessarily qualify for some of the post-acute care services or Medicare. So I think actually the observation stays, although I would certainly agree that the number of observation stays were increasing, certainly I think in 2012, I'm not sure that they would have an impact on the number of beneficiaries that were receiving Part A. It would only be that if the number would have gone, I think maybe she's making the argument that part of the reason the number of hospitalizations has gone down is because there's an increase in observation stay. And I think that is true. I think there are also other factors like shift to outpatient, and then I think also even the economy has had some impact on hospital utilization. So I guess the short answer is yes, it probably affected the hospitalization rate, which then in turn affected home health, but you can actually qualify for Part A home health if you have the op stay.
Yeah, right. I mean, actually, I think you're right. I think Barbara's making the point that if you had an observation instead of an actual inpatient stay, that would cause your Part A episodes to go down potentially, right? Although, it'd be nice to see the Part B episodes maybe pick up some of the slack, because you could still have a Part B episode, right, regardless.
That's correct.
But maybe I don't know. It looks like the Part B episodes are just coming down anyway, so it's interesting. Anyway, I'm going to do a last call for questions here. And the only other thing I'll point out is that, you guys have the chart in the chart book with the 30-day readmission rate. And then also, later on, there's the chart from Home Health Compare. It's table 7.3, showing that the acute care hospitalization rate went down from 17% to 16%. The only thing I wanted to just point out is that obviously that 30-day readmission measure is different from the ACH rate, because ACH is over 60 days and it's not readmission only, it's all hospitalizations. So, but to me it is interesting that, everything is sort of trending downwards. Okay. I want to thank our wonderful speakers and just remind everybody that we've recorded this webinar, and the slides from the webinar will be posted on the Alliance's website. I want to make sure that you guys know that you can always reach out to Ellen or Lily directly, or you can reach out to me, Teresa Lee, or to Jennifer Schiller if you have any questions whatsoever. And I want to thank everybody for participating today. Thank you so much. Have a great afternoon.